All right, so head trauma. So trauma to the head. So we have a fracture that can develop, right? Underneath that fracture, you can start getting a little hematoma that starts forming, right? It can be epidural or subdural, and it has different components. Usually an epidural is going to be like convex, or biconvex technically, and it's going to pushing in the brain, causing herniation. Is much, much more severe than a subdural hematoma. So we'll compare subdural and epidural hematomas. We'll look at skull fractures. They can be linear skull fractures. They can be like depressed, right? Like a cracked egg, right? On the skull. You can have fractures that are over this bone right here, the temporal bone, technically the pterion over here, the pterion with a silent P, a hard P, I guess, pterion, right? So it's going to be, that can actually be high risk for a epidural hematoma. Okay, we have TBIs and diffuse occipital injuries, and actually TBIs we talked about pretty much last. These guys are going to be, TBI is everything we've been talking about so far, right? Technically, any kind of hemorrhage in the brain is a TBI. Any kind of damage to the brain of any sort is a TBI technically, and there's all kinds of different levels of TBI and severities of TBIs as well. So linear skull fractures. All right, so linear skull fracture is where you have a little skull fracture on the brain, on the skull, not the brain yet. All right, so we have a fracture of the skull. It is considered a traumatic brain injury. It can cause damage to the brain inside, right? It can cause the brain to get contused, or not confused, but contused. Contusion can happen where the brain could go forward and backward, right? Especially if they hit the back of the head, right? And the brain could go forward and back. That could cause a coup contra coup injury, coup contra coup contusion. Anyways, it has cause a contusion, as it's like a bruising of the brain, or it can just cause a concussion of the brain. That's usually rotational injuries that causes that, where the brain gets jostled in the skull and cause a brain injury because of a concussion, or worst case scenario, a diffuse occipital injury. But we're getting ahead of ourselves. So skull fractures they can be a result of a trauma. So anytime someone has trauma, you're always looking for the mechanism of injury. What caused this? Because if they fell from 10 feet versus 2 feet, one's much more difficult than the other, much more worrisome than the other, right? If it's auto versus pedestrian versus bicycle versus pedestrian, one's worse than the other, right? So we look at those things for mechanism of injury. And also they might say, oh, they just hit their head in the cupboard and they got a basilar skull fracture. Well, no, you did not hit yourself in the cupboard. That's a sign of abuse if you're saying that, because to get a basilar skull fracture on the base of the skull right there, the linear skull fracture on the base requires a lot of effort. That's like a baseball bat kind of situation, or being hit by with a brick, right? So mechanism of injury can tell you more about, there might be something else that needs to be investigated. Okay, so here we got a lot of skull fractures, right? A lot of skull fractures occurring. We got skull fractures on the face. And we talk about skull fractures in the face, they actually have their own classification on the next slide. They're actually called Lafort, or Lafort if you're fancy, right? Lafort skull fractures, where those are facial bones, right? If you just have it on the top half of the skull, right? So top half above the base, I guess you could say, right? Because the base, when it's fractured, is called a basilar skull fracture. And if the top half above the base is fractured, that's called just a linear skull fracture, right? And those could be linear or they could be depressed, right? Depressed is just where you have a depression that occurs from the skull fracture. It's usually based on the mechanism of injury as well, right? They're getting hit with a golf ball. Well, that might be the reason why they have that injury like that, or a baseball, right? Or a fist, right? All these things can cause a depression. It's pretty rare for it to cause a depression and not tear the skin, right? That's pretty talented for that to happen. But usually 90% of the time, it's going to be a open fracture, right? Where they have damaged the skin, right? And it's going to also break through. This guy has a closed fracture, but it breaks through and causes a rupture of the skin as well. I don't have a good picture of the skin being open as well with a laceration. And of course, you're at risk for tetanus and other problems, right? So when it is depressed, it's usually comminuted. Comminuted just means it's many parts. Okay, so it's a lot of fragments that are in there. So all those fragments are technically comminuted, right? There's not just one skull fracture where you could maybe piece it back together. And really, skull fractures, there's no treatment for it, right? It's not like you're going to staple it back together. You're just going to let it do its thing and heal, right? If it is comminuted like that, you might then go in there and put a little bone flap or something. But for the most part, these are just supportively fixed, right? As far as the top half. Basilar skull fractures, you can't fix those. You can't go in there, take the brain out, take all the cranial nerves out, and okay, and let's go ahead and staple that together, right? That's not going to work, right? You can't just fix basilar skull fractures like that, right? Lefort fractures on the face here, you can fix those, okay? And we'll talk about those. All right, so we got scalp hematomas can occur as well. So that's where you can have a fracture underneath, right? You get a little fracture underneath here. These are actually suture lines, but you get a fracture of your skull, and it may or may not cause a hematoma, right? So if it doesn't cause a fracture, a hematoma may develop, and it could be either above the skull or below the skull, right? If it's below the skull, we have two varieties. We have an epidural hematoma and a subdural hematoma. We'll talk about those in more detail. One is below the dura and one's above the dura. One's below sub and one's upon epidural hematoma, right? So we have those different hematomas that can happen within the skull. If it happens outside the skull, you can have cephalehematomas, right? Cephalehematomas here outside the skull, or subgaleal or caput succedaneum, right? It sounds like an insult to someone who cuts you off in the traffic. Hey, caput succedaneum, right? So that's a hematoma that crosses suture lines, right? So these are different hematomas that result, and these are technically traumatic brain injuries. Does it really damage the brain? We got to find out if it caused any kind of concussion or contusion afterwards to see if you have any lasting effects. Right? So any skull fracture, again, can be superficial, or it can break the skin. That'd be an open fracture, and that puts you at risk for meningitis, especially if there's a tract for the bacteria to get from the skin all the way out into the skull, through the skull. Okay, it's uncommon, but it can happen. And then you have depressed fractures we talked about, and they can then cause epidural bleeds, which are arterial, right? Or they can cause subdural bleeds, which are venous. And the anatomy makes sense. We talk about those in more detail in coming slides. All right, and then this can definitely be a cause of traumatic brain injury, right? It can lead to a concussion, or it can lead to diffuse axonal injury. It can lead to contusion as well, which is its own little thing. Right, so those are other things that can occur when you have a linear skull fracture. We've got a skull fracture there. Then we have, what kind of skull fracture is this one in green? That's depressed, and right, that looks like that's a bullet fragment at that point, and that's going to be causing some intracerebral hemorrhage at that, which is again another type of TBI. Right, skull fracture is linear, depressed, comminuted, open. You got basal skull fractures or vault fractures, or that's anything above the base of the skull, right? And then of course we have the front of the face, which we'll talk about next. All right, so these are Leface fractures or Lefort fractures. All right, so Lefort fractures are just a skull fracture of the face. So they have three different types, right? So 1, 2, and 3. And the easiest way is you think of speak no evil, you think of hear no evil, and see no evil. It has to be in that order, like so. I don't know, SHS, all right, sh, or not sh, or sh, it's going to be sh. Okay, anyways, okay, crazy. All right, so you have these different, that's what's going on. You're not able to speak because your jaw mandible is fractured. You have a fracture of the palate. So number 1 is just the palate or the jaw is fractured. Okay, not so much jaw fracture, but more of the palate. I kind of misspoke, right? Because the jaw fracture is a jaw fracture that has its own thing with oral facial surgeons, and of course oral facial surgeons are going to deal with this as well. But we have our this skull is fractured right here, right? And we have a what's called malocclusion of the teeth, right? So the teeth are literally punched in, right? So they are, we have them try to close their teeth together, they're not going to close, on themselves, right? They're going to be off by a little bit. Okay, so that's speak no evil. We're unable to speak because we have a type 1 Lefort fracture, right? And then we have type 2, right? So type 2 was what? That's going to be our hear no evil. Okay, so they can't hear because we have done what? We've kind of fractured through the, not so much the palate, but like the sphenoid and these other areas over here. Okay, so we're cracking through the mid face, and the jaw is going to it can be fractured too, but we're really talking about the skull over here. You will have malocclusion as well, and you start getting your nose involved, epistaxis. Yeah, you could have epistaxis also with type 1, but these ones are where you're having you can start getting CSF leak from the nose, right? If we fracture through all this stuff in the middle here, right, then CSF, which starts getting made, and it's in the subarachnoid spaces, just waiting to come out, right? Gets made in the third ventricles, lateral ventricles, comes down the middle spinal canal, comes out via the fourth ventricle and the lateral caniculi and such. But then, yeah, if I create a little fracture, it can easily come out, and I can get a CSF otorrhea, right? It's not like an odorous CSF. That's a CSF that came out of the otos, or the nose, right? So CSF otorrhea is a type 2. Yeah, basilar skull fractures is technically type 3, but type 2 can start with that, right? So we have the sphenoid sinus there, and we have the pituitary sitting there, and this is our nose, not technically our nose, our nasal cavity, right? And now we have the CSF can easily go from point A down to point B, right, out the nose. So here's our malocclusion. I knew I had a picture of it. So you can see the malocclusion, the teeth don't line up there, right? That's type 1 or type 2, really. And then our last type is type 3, right? So type 3 is where we're not being able to see. So we have a fracture up at the top here. So type 3, we're cracking through the orbit. So the orbit is being cracked into, and therefore what's the back of the orbit is the optic nerve. So now they are at risk of not being able to see, right? So they have CSF leak out of the ear now. We're starting to get into more basilar skull fractures as we start cracking through the side over here. We're cracking through. Here's another version, number 3. We're cracking through that CSF, or so that CSF will leak. We're cracking through the base of the skull at this point, and we are at risk of cracking through the temporal bone. And the temporal bone is very, very difficult to get through. It's very, very thick in certain parts, the base at least, and that's a very, very profound mechanism of injury if that's what's causing, if that's what happened, right? So we have to look at the mechanism of injury to see, is there, does this explain what's going on, right? They got hit by a car, well, yeah, that makes sense, right? If they got hit at, I don't know, they said they hit their head on the cabinet, or they're always clumsy, they're always hitting themselves on the hallway. It's like that doesn't make sense. Okay, and you're going to start getting CSF leak out of the ear at this point, or CSF starts coming out of the ear if they start cracking the base of the skull. So Lefort fractures 3, or Lefort 3 is going to be a basilar skull fracture where we've gone through the base of the skull at this point. Okay, so this is again due to blunt force trauma of some sort directly to the face. And then now we're going to basilar skull fractures. So yeah, Lefort 3 causes basilar skull fractures, but this is where you get hit by a bat, for instance, and that's cracking the back of the skull, right? Or the bat hit the side of the skull. Here the face, now we're back to Lefort, right? But we have a basilar skull fracture, and things are starting to leak out of it, right, or out the front. So we can have a specific signs that tell us we have a basilar skull fracture. So CSF rhinorrhea, right, out of the nose, or CSF odor. Did I say that wrong before? I think I did say it wrong. So CSF otorrhea was ears, and CSF rhinorrhea is the nose, right? I was on the nose hike. Anyways, so CSF rhinorrhea, that's where we have CSF coming out of the nose, right? So CSF rhinorrhea, of course, goes from epistaxis as well. But how do you know if it's blood or if it's CSF? Well, you just get a quick little gauze right there, and you can see if you have a halo sign. It's not just something like cool, fancy trick that someone can say, look now, right? And they run, and it's like a huge puff of smoke. No, it's going to be an actual legitimate thing they can do to see if there is CSF present, right, on a gauze, to see that CSF is less viscous than blood, and it's going to come out further than blood on a gauze. Okay, so again, this is blunt trauma, right? And it's a type of skull fracture, and it has a really, really high mortality due to complications, right? It's not just oh, you got a basilar skull fracture. It's really, really high. It's 50% mortality. It's a coin flip whether they are going to survive or not out of the hospital, right? Luckily, it's not very, very common, but it's 1 in 5 patients that get skull fractures can develop or usually have basilar skull fractures. It's enough of a force to cause the base of the skull to get cracked through. Okay, and again, it's really conservative treatment. There's not much you can do. If they do develop meningitis, which is rare, then yeah, you could give some antibiotics for meningitis and fix that. But really, it's all very supportive, if anything. Okay, most common fracture is the anterior fossa, right? So remember, fossa is a place to, park your sofa. I don't know. It's a space that things sit in, right? So the fossa for the cerebellum is back here in the posterior fossa. The fossa for the frontal lobe, the base of the frontal lobe, sits in the anterior fossa, or fossa if you're fancy, right? So these are different areas that our brain sits. It's like, cool. Well, if I have a fracture there, I can fracture the cribriform plate. Where's my cribriform plate at? That's what's all my nerves from my cranial nerve. What? Which one? One or two? Cranial nerve. How many noses do you have? One. Cranial nerve 1 is where that goes through the cribriform plate down into our nasal passages, our nose receptors, and we're able to smell, right? So they can have absence of smell, anosmia, right? Is another symptom of an anterior fossa basilar skull fracture. Okay, and we mentioned CSF rhinorrhea as well, and then periorbital ecchymosis. That's pretty specific. It's 90% sensitive for a basilar skull fracture of the anterior fossa. So 9 times out of 10, if they have what are called raccoon eyes, right? They got eyes that look like raccoons, right? They are it's a very, very specific for someone that might have a basilar skull fracture, unless they like makeup. I don't know, right? So they have different. What's going on is you have this periorbital ecchymosis, so that trauma starts causing, petechiae and little tiny hemorrhages in there and bruising to occur, and we start getting a periorbital ecchymosis. It doesn't have to be bilateral; it can just be one eye or the other. Okay, so this one over here you can see is both eyes are raccoon eyes. Okay, so obviously we're going to start, might fracture the base of the skull back here, and remember all those little holes, a lot of what goes through those holes, all the different cranial nerves, right? So cranial nerve 1 went through the cribriform plate, right, up top there, and all the other ones went through, the sphenoid had a lot of different holes in it that that you had to describe back in anatomy class, right? All these different things now we have fractures. Now we have cranial nerve dysfunction can occur, right? So cranial nerve 3, cranial nerve 2, all these things, 4 and 6, all those ones can start getting impinged upon because you have a fracture there and localized swelling and edema. Okay, so blindness is a complication. You get a tension pneumocephalus. What is that? It's not a tension pneumothorax, it's tension pneumocephalus. Cephalus being the brain, right? So air goes into the nose, right? And it can't come back out. It's trapped, right? So that can start compressing the brain a little bit, cause a little herniation. All right, the middle fossa, about 25% of our basilar skull fractures, and this is where we get CSF otorrhea. This is the proper otorrhea, not the otorrhea I talked about in the previous slide, right? Nobody corrected me though, so I guess I could have just played it off. Anyways, CSF otorrhea, all right, that's where you have a leakage of CSF out of the ear, right? So CSF's leaking out of the ear in this case. You even see kind of a little bit of halo sign happening there. Okay, so that's a sign that the tympanum has been ruptured, and also that there has been CSF that's leaked all the way from the temporal lobe all the way down through that crack right there into the out the ear. Okay, does it have to go through the tympanum? Not always, but it might. And hemotympanum is a very, very specific sign of a rupture of the temporal bone. If you look at the temporal bone anatomy, right, you have your ear canal here, and there's your ear out on the back end, and you have your eardrum right there. Attached to your eardrum, you have your malleus, incus, and stapes, all the fun stuff, and it's attached to the cochlea and such. But what surrounds this is all skull, right? There's all skull right here. So if we have a crack through the skin here, or a crack, what color is a crack? Crack is, what's crack in real life? I don't even know. Blue and Breaking Bad. All right, so we have, that's meth though. Anyways, I'm getting really distracted. I had no sleep. All right, so we have a crack of our bone, our temporal bone here, right? And then now CSF can follow through, but also we can have, some hemorrhaging and some damage to our tympanum or our tympanic membrane. Okay, and of course now we start getting the cranial nerves that go through that can get affected. Okay, and then we got our posterior fossa. So our posterior fossa, quite rare, but it can happen, or back of the brain where our cerebellum sits, and that's worrisome. The cerebellum might get damaged or contused or even have a hemorrhage. and they can be posturing, and that's not great, right? And that can definitely lead to herniation, infratentorial herniation, because we know that this is just an open spot for the brain to sit in. It's separated by the tentorium, right? So we look at the cerebellum down here and our cerebrum up top and our pons and medulla, right? That looks like a face. Anyways, we have our tentorium that separates it right here, right? So again, that's a very, very narrow space or a box within a box that can easily expand if we have damage here, right? And that can spread. Okay, so there's some different nerves that go through the back end over there. If we look at closely at all of our nerves that went through the back end of the occiput, so we can have some kind of 9 through 12 involved. All right, so those are our different basilar skull fractures and the results of them. And then just to recap on your anatomy and your bone holes, right? So we have different holes that are going through it. Here's an example of the pneumocephalum, right? Air is absolutely pitch black on X-ray and CT scan. So you can see all that air has gone in because of a basilar skull fracture. We had a fracture up top there. Okay, but as you know, there's holes in the bone. There's holes for like the jugular vein, right, on both sides. There's holes for the carotid up there, right, on both sides. And then we have everything else is pretty much a nerve hole, right? So we have all these nerve holes over here, the temporal bone. We got the cribriform plate up top for our cranial nerve 1. And then we have, cranial nerve 2 kind of goes up right there through the sphenoid, right? And then we have our occipital lobe is involved as well. So these are all the cranial nerve bones or cranial nerve holes that can be affected if we have a fracture there, right? We have a big old fracture that cuts through one of these holes where the nerve is going through. You can see all these nerves are going to start to be affected, right? So here we have another side view, right? So we cracked through those nerves there, through that bone there, and now these nerves are affected, right? So cranial nerve 8, cranial nerve 7, all these nerves are being interrupted in their normal function, so they can have those focal deficits because of that trauma. Okay, so if someone has a anterior fossa fracture of some sorts, okay, so if someone has an anterior fossa fracture of some sort, right, you want to be very careful to put an NG tube in so that you don't go into the brain. It's like, oh, I put an NG tube in and now they're altered. It's like, oh, they're altered because there's an NG tube, inside, meeting with their childhood memories at this point. Okay, so we want to make sure that very, very carefully if you're going to put an NG tube in. Yeah, it'd be, they want to get a CT scan first. Like, yeah, it's probably not a good idea to put an NG tube at this point, right? An OG tube would probably be better in that situation, okay? So yeah, cranial deficits, we got bleeds that can happen, right? We start crimping the style of this carotid right here, right? We crack through that. Now that carotid, it doesn't get adequate flow. It's more turbulent at this point. And then we are able to, you could get thrombuses. In arterials, it's a little more difficult than definitely a venous thrombus, right? A sagittal sinus, or the venous drainage down into the thorax, okay? And again, do not intubate the cranium with a basilar skull fracture. It's not best practice. Okay, so depressed skull fractures. All right, so our depressed skull fractures, these are fractures that are causing an indentation, as we kind of talked in the overview, right? Usually it's very, very common for there to be a laceration associated with it. It's very, very difficult to get punched in the forehead and to just have a depressed skull fracture, right? This guy's like post-MMA fight, and he has a depressed skull fracture there, right? So what are the symptoms? You can lose consciousness with this, right? If it causes a significant contusion, right? As the brain goes forward and backwards, it can cause, concussion, cause contusion. This definitely is a much more prominent comminuted fracture, as the fracture has gone through the skull at this point and has then entered into the brain. All right, so we have a comminuted fracture, especially if that's open right there, that's definite high risk for meningitis, right? As an introduction spot for our for bacteria, right? So brain trauma, especially if it's gone all the way through, right? That can then lead to cerebral edema. All right, so we're over here on depressed skull fractures, got blunt traumas with bony defects can cause more damage. And this could put you at high risk for epidural hematomas, which we'll talk about, especially if it's over, this says subdural. Let's see if we got a better picture here, but a little bit lower right there, that's called the pterion bone, and if that gets fractured, that's the thinnest skull, thinnest piece of skull in the whole skull, right? It's the thinnest area, and it's easy for it to get fractured, and that can easy for what sits right underneath it, right? This was not well planned out. So let's make the thinnest part of the bone of your skull be right here, and that's going to be, I know what's going to put under that. Let's go ahead and put a artery under that, right? So that artery can easily be ruptured and cause an epidural hematoma. If they just had like the vein there, we would have been fine, right? But it's an artery, unfortunately. All right, so meningitis as our complication of a skull fracture or any kind of basilar skull fracture. Yes, it's rare, but we can have infection that can make its way into the brain, right? And this slide covers meningitis in general. So meningitis you get from bacterial sources from the community, or you can get it from nosocomially in the hospital as well, right? If we have a ventriculoscopy in place, an extraventricular drain in place, you get encephalitis, but you can also get meningitis, right? So there is bacterial meningitis and viral meningitis. Usually if you have a trauma, it's going to be bacterial because there's bacteria on the ground, bacteria on the bat that you got hit with. There's different things that are going to make their way into the bloodstream. And what sits on all of our skin is staph and strep, right? So staph and strep are pretty common as a cause of adults as well, or as a bacteria that causes meningitis, right? You can also get meningitis when you have a recent viral infection or a recent pneumonia, right? And what causes pneumonias are staph and strep and Haemophilus, right? So those are our common pneumonias. If you're immunocompromised, you can have a special guy over here, Listeria, can show up when you are immunocompromised. So immunocompromised is Listeria, is a bacteria that needs to get, ooh, it's changing colors. All right, so immunocompromised patients are high risk for Listeria, right? Otherwise, we got to cover for gram-positive, gram-negatives, right? So our streps are, staph and streps are gram-positive, but then we have like Neisseria and Haemophilus are gram-negative. So we want to cover for that, right? So gram-positive, we're gonna hit them with the strong stuff, hit them with the vancomycin. It's one of our stronger agents for gram-positives. And then Haemophilus and Neisseria are gram-negative, so we're gonna hit them up with some broad spectrum stuff, right? And one of the agents would be like ceftriaxone for a mild bacterial meningitis. Okay, so meningitis, what are the symptoms? Right? How do you know someone has meningitis? They have fever, they're altered, and they have meningismus. So we talked about meningismus over in subarachnoid hemorrhages, right? When you have a subarachnoid hemorrhage, it irritates the brain, right? And it irritates the brain meninges. And the meninges are different layers down here, right? So different layers are able to get inflamed. Okay, so we have, yeah, the periosteum and the bone. All right, so meningismus, fever, LOC, change, and meningeal symptoms as we are irritating these meninges down here. Our dura mater, pia mater, and our subarachnoid layers are all going to be, our arachnoid layer technically is going to be irritated right here. So our dura mater, our arachnoid layer, and our pia mater, all these are going to be irritated. Obviously, these are going to be probably irritated first, going inward, outward. It just depends on where the infection is coming from. But the point is that you got fever associated with this, whereas like when we have meningismus with subarachnoid hemorrhage, that then caused that just didn't have a fever. That was just irritation of the meninges because of blood that was irritating it, right? It was more at the base of the brain, more than the top of the brain, right? There's some other signs you can do, like Koenig's sign and Brudzinski's sign, right? Where you lift the knee for key, with a silent K for the knee for Koenig's sign, right? And Brudzinski is where you hit the back of the neck to cause meningeal irritation. And they'll reflexively want to raise their legs so that the pain goes away. So those are, there aren't just like cute things you can do like for Hohenstein. Like Hohenstein is like a cute thing you can do for DVT that's accurate like 50% of the time. But this is actually something that has a little bit more specificity. As you can see, it's about, was it 44%? Where's it at here? That's sensitivity. Sorry, 95% over there, right? And then there's other things you can do. There's called jolt accentuation. So jolt accentuation is actually jolt, where they move them and they move all of a sudden, right? It's very, very irritating, like you get startled almost, right? And then Neisseria is very, very deadly, And we have meningitis, or due to Neisseria meningitidis, that is going to be causing a profound meningitis, profoundly more sick patient, and also it's going to cause a non-blanchable petechiae, right? I think I was scared of this back in nursing school because it has like a really extremely high mortality rate, and whenever I got like a rash, like okay, it's blanchable, I'm good. All right, I don't got meningitis. Right, so now I just instilled that fear to you. You're welcome. All right, so yeah, so it causes petechiae that are non-blanchable, and you start getting a fever, you start getting a little altered, you start getting neck pain, nuchal rigidity. Then we're starting to consider it might be Neisseria, right? And Neisseria is more common in kids, but it is a valid bacteria or piece that could cause a meningitis, right? So vancomycin we mentioned, ceftriaxone we mentioned, and steroids are indicated because this is an inflammation process. So steroids will be a little more anti-inflammatory and prevent cerebral edema from getting worse. And of course, seizure activity is a worry, especially if we start getting more hydrocephalus, right? Because we start swelling into these areas here, you don't get good adequate flow, and this widespread cerebral edema can cause widespread ICP elevations, and of course can put us at risk for herniation. All right, the difference between bacterial and viral meningitis, one is worse than the other. So viral is definitely very, you don't get admitted basically with viral meningitis. Or if you have a patient with viral meningitis, it was incidental that they had it, right? They had a recent flu or recent pneumonia, and now they have viral meningitis, right? They have the fever, photophobia, they have all these different symptoms, headache and such, but it wasn't to the point where they're altered and they have a decompensation, right? So that's kind of the key difference between bacterial and viral, is that one is more severe than the other. You can see that bacterial is the more severe one. Viral is just a more mild form. And you're not going to give antibiotics for this, right? Because antibiotics don't work on viruses, right? So it's just supportive care. That's just, you just monitor it. Okay, so the different bacteria that get affected, we're going to be then giving our medications for this. And also, just to add here, listeria, you're going to be giving ampicillin. That's just one of the key things. You'll see someone's like, why is a patient on ampicillin? Either on vanco and ceftriaxone. That should cover everything. Listeria is resistant to both of those. So listeria is one of our agents we have to add on top of, especially if they're high risk. And those that are high risk are those that are usually age more than 50, but also those that are immunocompromised. Those would be a high risk patient that will require listeria coverage or require ampicillin coverage, right? So that's something to also consider if the patient's not on it. It's like, do we need to have ampicillin also? All right, so lumbar punctures. Lumbar punctures are one of the ways we can find out if someone has meningitis, bacterial or viral, right? So here's acute bacterial meningitis there in dark blue, which looks great, right? So this requires a little bit of touch up. But you can see here bacterial as well. If we're comparing our white blood cell count and our glucose count, those are usually the ones we're going to be seeing the differences in, right? Viral meningitis, you might see little white cells go up a little bit, but the glucose will be normal, right? The glucose is low in bacterial meningitis, right? So it's 50% of the blood. So if my sugar is 100 or 120, let's say a perfect sugar on a patient, what's 50% of that? 60, right? And if it is less than 60, that is going to be a bacterial meningitis until proven otherwise. That's the most common one. Are there other rare, weird bacteria out there? Yes, there's like tuberculosis meningitis. You could get a syphilitic meningitis, which is not really bacterial, it's a spirochete. But there's different things you can get that you can get out of the LP. Right, the LP can tell you if someone has like an autoimmune disease, right? If they have Guillain-Barré, is another thing you can look at for LPs. How's an LP done? It's done via the L3, L4 interspace. They usually want to have them knees to chest, right? That's going to open up the space right there, so they can get in there and they can pull out a little sample of CSF, right? The spinal cord ends right above that, so we don't want to hit the spinal cord, otherwise now they're paralyzed. So we want to make sure we are pulling from the little space that's there, right? Not going too high, usually not going higher than this iliac crest. That's usually kind of our limit, right, when we're doing LPs. All right, LPs can be done in the ICU. Oftentimes they want to do an LP over an IR, right? I need to get a picture of it because I can't imagine what it's looking at as well. And when they do an LP and IR, they say, oh, we got to make them prone. It's like, we can't take your vented patients over there while they're prone. It's like, well, we can prone our patients. It is possible if you want it, right? But otherwise, your ICU patient can be put on their side, and you put knees to chest, and we can grab our sample from the interspace there where the CSF is flowing, right? And you want to get a sample. They usually do 3 test tubes, 4 test tubes is like a little overkill. But obviously, if you have a bacterial infection, you get pus. Well, you're not going to get pus of the CSF. You're going to get a cloudy CSF. So instead of being clear, it is cloudy CSF. And what's the glucose at again? Glucose is low, right? 5 to 40 in this case, right? So TB might be a little bit low, but TB meningitis is very rare, right? We're talking about the normal stuff, right? And why is it purulent? Why is it cloudy, right? That's because of white blood cells, right? So white blood cells are very, very high in the CSF. Okay, so our complications of meningitis, as we mentioned, you got seizures, you get effusions in there, cranial nerves can start getting occluded. Right? At first, they'll have the fever, change in mentation, the nuclear rigidity, meningismus, but then later they can start getting inflammation around the cranial nerves and start getting cranial nerve deficits and getting focal deficits because of this, right? DIC is more common with Neisseria meningitis. That's also why you're like, oh, I got petechiae. Oh shoot, are they blanchable or non-blanchable? Which one do you want? Yeah, and then you're gonna wake up in a cold sweat tonight. It's like, which one's the one it should be, blanchable or non-blanchable, right? So yeah, so you want to make sure that if they have non-blanchable petechiae, it could be at risk for Neisseria. Okay, so what else on this, right? So we want to make sure that we have when you get samples, you want to make sure you send these samples to lab, right? It's hand delivered, right? So hand deliver your samples, right? Because oftentimes you'll put it in a bag and then you put it in like the to-go bin, right? So whenever you go downstairs and you drop off the sample, it needs to be literally handed to someone who's going to run the test. You can't just put it there and say, I pick your promise, I got it, right? Because they'd be going on lunch, they come back and they forgot, they get a stat call. It's like, we need a transfusion, a massive transfusion over here, right? So there's the whole thing that can get distracted. So you want to make sure, since we're going through this whole procedure, which is very invasive, requires consent and everything, and we need to make sure that they are not going to lose the sample that we spent all this time to get. And it's not always easy. When they're nice and thin and young, it's very easy to see all the interspaces, all the ridges there, and to go in, you can see all those ridges, super easy. There it is, there's L3, 1, 2, 3, 1, 4, and you can easily get it. But when they're a little more American, like a little more obese, they have a higher BMI, you can't feel a spine to save your life. So you're really like, where is it at, right? And then the other thing to consider before an LP is done, especially as the nurse, is are they at risk for herniation, right? Because if I put a hole right here, what's going to happen? Things always go from high to low, right? So someone has a high ICP, and as we mentioned with meningitis, you can get abscesses, you get strokes, you get all these different problems, effusions, and that's going to start raising the pressure in the brain, right? So we don't want the pressure in the brain to be so high where the brain comes out of the hole you placed in the spinal cord. Right, so that is, if you ever saw that event, it always haunts me with these guys, these deep sea divers, and some guy just like flipped the switch, right, and it was too soon, and the pressure was too high, and then all 8 guys were brought through a hole that was the size of a pen, right? All their body parts ever went through that tiny little hole. That's what I think of in this situation, right? So I wasn't watching. I read some random. It was also late at night, probably, right? So it was some different. These lectures are much more entertainment. I don't get sleep. Anyways, you have that's a high pressure to low pressure. Basically, everything goes high pressure to low pressure. You want to make sure that we don't have a high ICP before an LP is done, right? In that case, he was like, well, why don't we get a CT scan first to see if it's safe to do an LP, right? And how would you know that someone has high ICP? Well, you can dust off the ophthalmoscope that never gets used, right? It's like, let me take a look at your eyeball, your red reflex, look at the back of your retina to see if you have papilledema. There might be a neurologist that might come in there that will do it, but you're looking for other signs. You got a blown pupil is probably not a great idea. Yes, you can have cranial nerve deficits with meningitis, but we definitely want to see if there's history of CVA, if they have a change in LOC, right? They can't answer 2 consecutive questions. Like, well, if I'm intubated, how am I going to answer 2 consecutive questions? So there might be a change in mentation that we got to be alert to. The immunosuppressed are higher risk. They got a focal deficit. All right, they got a seizure activity, right? Seizures weren't classic for meningitis, right? Seizures were in the complications column. That's a complication that can occur from meningitis. So if they have seizures, that's probably a sign that we should do a CT scan first before we do an LP. Okay, otherwise it'd be a catastrophic herniation.